is a congenital anomaly of the lung. That is to say, there is an inherent defect in the lung. Typically, it will have cysts and blebs. These things can rupture at any particular point in time. And when they rupture, they, of course, are associated with a collapse of the lung or a pneumothorax. Now, there is, of course, an ongoing risk of reoccurrence. The reoccurrence is quite substantial. In fact, about 50% of these patients will have a recurrent pneumothorax in the next 2 years. It has a fairly high association with cigarette smoking as well. Now, even with the treatment of a pneumothorax, which typically involves medical management, like pleurodesis, a scarring, or surgical tacking of the lung, there still, though, is this ongoing risk of rupture of these congenital blebs. Now, surgical management certainly is very effective, but there's concern that if a patient were to rupture a bleb, even a very small area could re-expand, again, in accordance with Boyle's law, and we could develop a tension pneumothorax, because with each atmosphere, we are exerting 14.7 pounds per square inch. And with that kind of force, even the best surgical tacking may possibly be torn and ripped away, inducing a potential life-threatening tension pneumothorax. Now, it is a relative contraindication, however, in a multiplace chamber. As you saw earlier in our opening sessions, in a multiplace, you can actually go into the chamber, listen to the chest, make a presumptive diagnosis of a pneumothorax, and place a needle in there by decompressing. But in a monoplace, there's no way we can reach that patient to touch them. And any attempt to return to the surface, again, Boyle's law, the gas can expand further, causing compromise and producing a very serious situation. So, spontaneous pneumothorax, considered to be an absolute contraindication in the setting of a monoplace chamber, but in a multiplace chamber where we can reach the patient, one certainly could proceed with treatment. So, if you have a patient with a history of spontaneous pneumothorax, you may wish to refer them to a multiplace facility in your region. Now, this is also considered to be an absolute contraindication for scuba diving. I occasionally reference this thing about diver clearance because many of you now, being involved in hyperbaric therapy, you will probably be one of the most knowledgeable individuals in your community. And accordingly, scuba divers may seek out your knowledge and expertise and look for dive clearance. And if a diver has this history of spontaneous pneumothorax, again, sports scuba diving is certainly not necessary or essential. And even though it may be a small risk, a remote risk, should any diver have an unfortunate occurrence of a pneumothorax at depth, the attempts to return to the surface could prove fatal. Now, in contrast to a history of spontaneous pneumothorax, a patient with a history of deserved pneumothorax is acceptable for hyperbaric oxygen treatment. So let's just draw on a case illustration here. Let's say that you have a 45-year-old male. He has a non-healing diabetic ulcer. As you proceed through the history, you ask him if he's ever had any kind of health problems. He said, well, yes, doctor, I have. When I was 18, I had a motorcycle accident. I cracked a couple of ribs. They said I collapsed my lung. Look here, I've actually still got the scar. Well, that's what we would call a deserved pneumothorax. We understand why that lung collapsed. Let's say that you're talking to another patient. This one is 65 years of age. They're suffering from chronic refractory osteomyelitis, another indication for HBO. In the course of the history, you ask if you ever had any kind of medical problems, and they say, well, yes. Actually, a couple months ago, they were putting in one of those special lines in the neck. I think you doctors call it a central IV. And in the process, they said my lung collapsed. They were putting this IV in so that I could get my antibiotics to treat my osteomyelitis. Well, again, we understand why that patient collapsed a lung having a central line placed. So these are examples of what we call deserved pneumothoraces. once that pneumothorax is resolved, then certainly HBO can be provided. And that's in sharp contrast to the congenital anomaly of a spontaneous pneumothorax. So again, the presence of a spontaneous pneumothorax would be an absolute contraindication in a monoplace, but a relative contraindication in a multiplace. All patients with deserved pneumothoraces, though, certainly could be treated with HBO, and even with a ongoing pneumothorax, if they've had a chest tube put in, as we commented earlier, this too could actually be treated. So that really concludes our list of absolutes. So now what we're going to look at is what I simply call relative risks. Not even contraindications, just relative risks that you should keep in mind. And the first one we're going to look at are patients who have had carbon monoxide poisoning so severe that they required CPR, cardiopulmonary resuscitation. And in this report, published in the American Journal of Emergency Medicine, the authors looked at 297 consecutive cases of CO poisoning. And they noticed that when CPR had been provided, that the incidence of a tension pneumothorax for patients on the ventilator was as high as 12%. Now that's 1 in 10 patients. It was high enough that the authors commented that prophylactic chest tubes should probably be provided for anybody who's had CPR and being placed in a monoplace chamber. Now again, if you have a multiplace chamber, one could certainly do needle decompression should this occur, but with a risk of 1 in 10, even there you might wish to consider that. Now the next relative risk to consider are patients who have a history of thoracic surgery. Oftentimes in textbooks you will read authors expressing concern that with prior thoracic surgery there may be a risk. Well, the concern is certainly understandable, but I find that oftentimes that kind of concern is simply too general of a concern. Certainly it's good advice to always be cautious. When I get out of bed in the morning, I suppose it's good to be cautious. And certainly with a history of chest surgery, it's good to be cautious. My personal case experience treating many patients with peripheral vascular disease, which of course has the associated coronary disease, and back in the 1980s with many of these patients getting open coronary bypass grafts, really had no untoward problems. So again, this is sort of a general unqualified concern. As you read these things in textbooks, it's sometimes difficult when you're new to a field to know how big of a problem is it. And again, I think it's sort of an unqualified concern. One should always look at a chest x-ray and just use good clinical sense in approaching these patients. Certainly using slow ascent rates at 1 pound per minute is useful. Now, on this matter of ascent rates, the typical ascent rate that's used at many programs is 1 pound per minute. So oftentimes what is done is we compress at 1 pound per minute going to 2 ATA and decompress at 1 pound per minute coming back from 2 ATA. Sometimes at higher pressures people may wish to accelerate the compression some. Now I know we have yet to even talk about indications, but it's useful at this particular juncture to draw on another piece of that puzzle I spoke of earlier in putting together the big picture of hyperbaric therapy. Another relative risk to think about would be any patient who has an abnormality on X-ray or CT scan. Again, the concern here is that if you have some pneumatoceles or blebs or bulli, that these could possibly trap air. Again, in accordance with Boyle's law, the gas, if it cannot escape easily, could expand, resulting in possible rupture. So the central question really is whether or not that bullus ventilates properly. Now this can sometimes be problematic. Sometimes people will use detailed CT scans. That can be useful. Xenon lung scans where you inhale a radioisotope and then you wait to see it clear. If the bleb is not clearing the isotope, it suggests one of two things. Number one, there could be air trapping, and certainly number two is there could just simply be poor ventilation. That is to say, it is open, but it doesn't ventilate well and not necessarily trapping. Consultation with your pulmonologist can also be useful in gaining further insight. And at the end of the day, you'll just have to make a clinical decision. After all, in this business, they don't give us a crystal ball. Let's move on to another area also related to the lung. And this would be patients with obstructive lung disease. Now, in this category, we have a number of considerations. We have patients who have asthma. That certainly is a form of obstructive lung disease. And then we also have our patients who have COPD, chronic obstructive pulmonary disease. In this category, there really are two types of COPD. The first is what we sometimes refer to as emphysematous disease, and the other is bronchitic disease. In medical school, I was taught the colorful metaphors of the pink puffer and the blue bloater. So let's take a minute here and examine this topic a little more closely, because a lot of your patients, certainly being seen in the wound healing center, have had a prior history of smoking. After all, it's the smoking that brings on the peripheral arterial disease that ultimately results in the slow, chronic, non-healing wound and a hypoxic wound bed. So following your transcutaneous studies, you may wish to employ hyperbaric therapy as part of their management, but there may be concern regarding the severity of their lung disease. Now, patients with COPD, as I mentioned, can be divided in those two broad categories. For the patient with emphysematous disease, sometimes called vanishing lung syndrome, these patients have a problem with oxygenation, but they seem to ventilate pretty well. That is to say, their CO2 levels are normally within the acceptable range of about 40. They just have problems with oxygen. 2 liters of oxygen promptly corrects that. So these patients usually are acceptable from a risk perspective for HBO. Again, one would want to get chest x-rays and consider a few other aspects, but it's the blue bloater where there is greater concern. These are individuals who not only have problems with hypoxia, but they also have problems with hypercapnia. That is to say, they have a ventilatory problem. Now, in looking at these patients, certainly the concern about the hypercapnia is that if you give them too much oxygen, they may stop breathing. Or do they? So let's examine this concept a little more closely. What's traditionally been taught in the past is as you begin to develop higher and higher CO2 levels, the patient habituates. That is to say, carbon dioxide no longer becomes a stimulus to breathe. There are two things that really drive respiration. One is hypercapnia, carbon dioxide, and the other is hypoxia. So as they become habituated to the higher and higher levels of carbon dioxide, now the primary stimulus or drive to breathe is really oxygen. And the concern is if you give them too much oxygen, you stop them breathing. Why, I've had paramedics bring patients to the emergency department with severe COPD, and they don't give them oxygen. I ask why. Oh, well, doc, I don't want to stop them breathing. Of course, I look at the patient, they're kind of blue. I say, you know, they're not looking too good right now. So in the back of an ambulance, you are in constant attendance, and if the patient is cyanotic, then you should give them oxygen. So where the real concern is in the long-term medical setting. So let's say the patient with COPD is admitted to the hospital. They have an elevated PCO2. They're put on oxygen, a higher dose of oxygen than they're normally accustomed to, and the nurse leaves the room. Now, when will he or she be back? Well, it could be 4 or 5 hours later. They've got a lot of other patients to see, and in that interval, because of the higher oxygen they're being exposed to, they no longer breathe as frequently. So their respiratory rate had formerly been 16 per minute, now declines to 12 per minute. And because they're breathing a little slower, their CO2 rises even further. Now, the effect of hypercapnia, even higher CO2, is one of sedation. With the sedation, they become more drowsy. Their respiration declines even further to perhaps 10 per minute. Now, when the nurse comes back, what they might